Center of Excellence for the diagnosis, the treatment of Lassa fever, which you are no doubt aware is a killer disease, more dangerous than HIV, which everybody is talking about. We've been able to develop the capability, the resources, the personnel to be able to combat this killer disease. For a young hospital, at least we boast the pride of place. We have a tertiary, we have facilities and infrastructures and personnel that can rival any older teaching hospital. We have up to 84 consultants in the hospital in the various fields. In that spread around neurosurgery, cardiothoracic, and then we are almost number one in most training institutions in the residency training program. The places we've developed quite a lot since we took off in 1993, and I think that by the time you go around, I think you'll be able to not distinguish our center from any center of excellence anywhere in the world. So thank you very much. Thank you. So welcome. So yes, sir.
What are the two most important
Okay. Yes. Yes. Yes, we have a few projects that are ongoing. We have the theater extension, we have the labor ward extension, and we have the Lassa fever complex.
In terms of equipment, what are your latest completed projects?
No, we have the ICU has been completed and it's been intensive care unit, yes. And yes, the Lassa fever center, yes.
In terms of diagnostic,
we have the Lassa PCR machine, actually the first of its kind in this part of the world, and then we have our labs are state of the art, so to speak, if I have to use that word. But basically, we're able to make a diagnosis, like say a DNA diagnosis of the Lassa fever, rather than the clinical diagnosis, which is what most centers do.
You generally treat house officers, or do you train?
No, we train residents. Actually, for our center, we've been a training center almost for more than 15-20 years now, and we have graduated residents and consultants from the various departments: obstetric and gynecology, surgery, medicine, pediatrics. House officers are actually the first cadre that we just do a 1-year program, but we probably have one of the most robust training institutions. That's like our pass rate is at the part 1 and part 2. Special portion of the specialization program is, it compares with anywhere else in this country.
So which unit?
Okay, we'll go to the ICU complex. Okay, yes. Monitoring critically ill patients. We have a full complement of anesthesiologists. We have up to 4 anesthesiologists, constant anesthesiologists on the ground. And then we have about 8 residents in training. In addition to training, of course, the residents also have an MOU for training medical students from 1 or 2 patients inside. But it's quite large. Yes, it's way around, yes. We can book in-surgical procedures all at once. Even in the group, we can book like 4 surgical procedures. But with this, even at leaving about 4 empty, we can do 10 at once. So if we want to expand, we can do 14, 15 simultaneously, if we want to. And that's we are 350 right now. We started off as 230 at the beginning, but we're actually projecting that by the time we finish the labor work complex, we'll be pushing 550, 600 beds. Being operated by MTN. The part of the building is what is being leased to the community health department. We right now the department has a full complement. We have up to 5 consultants in radiology. We are training residents and medical students. So let's just say by the end of March, we should have a fully functional modern radiology complex, especially with the delivery of the CT scan. because at least that to a great extent will help our operations. Sorry, it's a 32-slide CT scan. That's we are doing it under a public-private partnership project. Yes. Yes, for now, that's what he offered, but he says that it's expandable, it's upgradable. But because part of the problem, he said that he needed to bring that one, is for easy maintenance for now. But of course, we know that they're higher. Yes, we know about 64, but it's the one we can manage of. Yes, but it's the one we can manage now. That's what we are trying to. That's like.
Technology is better to look for.
Well, the problem is that we never had before. So what we are
have the latest so that you don't bring one, then they will tell you the new model.
No, he says it's upgradable. That's what they promised. So by the grace of God, we should be able to. When the public-private partners.
The private partner.
No, where what's the name again? We've not really selected. We've not really selected. There are 3 of them. Yes.
Okay. One on the private participant. The specification is better you try the specification process. That you go for what is latest and then grow up with it. And go backward. When the technology is back.
No, you have a point there. Okay.
Find that now.
Okay.
The people don't have to define it.
No, I guess when we select the partners, at least we'll probably just take that into consideration. Yeah, that's the labor ward complex. That's
You have gone more than the watch for the man since already.
They've closed for today. They come. Yes, we have 10 labor ward suites. Actually, it's going to take care of most of the major procedures in obstetric and gynecology. 10 labor ward suites. It has is a 50-bedded almost semi-hospital complex, and it has offices. It has a research center, and hopefully it's also going to be the center of the IVF unit, which we are hoping to bring also, because we've already completed plans to be able to start an IVF. We sent a few people for training within this institution, and we feel that alongside UBT, we should actually be the second government tertiary healthcare institution to start the IVF program. And considering the number of patients who require IVF, we think that we have almost like a captive audience, and we have quite a lot of people who actually require the procedure. Our price is going to be very competitive, much better than most other places, and it is better than the private sector. So we're going to have a station where I will be the nidus of our obstetric and gynecological practice in this part of the country, rivaling any teaching hospital in the South.
Minister works. You are welcome to the Institute of Lassa Fever Research and Control in Irrua Specialist Teaching Hospital. Lassa fever, as you may have been aware, is a viral disease that is caused by the Lassa virus that was first discovered in Nigeria in 1969. But now today is found in several West African countries of Sierra Leone, Liberia, Guinea, and even Ghana. Of course, Nigeria is endemic for Lassa fever. And then some years now, the management of this hospital thought it wise to tackle the problem headlong. And we decided to institute a more elaborate process for it. We started this institute. The institute is made up of several units. The diagnostic, where we conduct tests for Lassa fever using what we call the polymerase chain reaction. Within 8 hours, once the patient arrives who is a suspect, we're able to say it's Lassa fever or not. This is against what we used to have when we have to send samples to Germany, to South Africa. And within 3 weeks to 4 weeks, you don't have the result. But today, within 8 hours, any part of this nation, they send samples to us, we're able to say this is Lassa fever. And this year alone, we have had samples from Kebbi State, Taraba, from Boeing, from El Delta, from Ondo State especially. And of course, from Edo State, that's endemic for Lassa fever. Edo, where we are. Then this is the diagnostic facilities. Primarily, Lassa fever is transmitted to man from contamination with rodent feces and urine. When they contaminate your food, or contaminate your bed, maybe plates and spoons, inadvertently when serving meals, you can have Lassa fever. Or secondarily, somebody that is infected can also transmit it to other persons when the blood or the body fluid of that person touches your mucous membrane or broken skin. And then sometimes we think that through aerosols, that is, if you sweep the ground and then the dust start to fly in the air, somebody might also contact Lassa fever. And then some cases too, maybe sexual transmission, because we had cases of husband and wife coming down with Lassa fever. So in some families, you can have Lassa fever occurring in 4 or 5 persons at the same time. In 6 days, if they come on time to this place, there is treatment for it. On my right side is the isolation ward of this hospital dedicated for just Lassa fever, to separate them from the other patients in the hospital so that we manage them. So we have clinicians that manage them after diagnosis. Then also on my right, on the front there, you have the critical care unit where we dialyze patients who actually go into complication of Lassa fever, that's renal failure. So we dialyze them, and then we're able to recover some of them so that they don't die. And then we have another department for outreach. Our vehicle in front there goes regularly to the village to follow up these victims of this Lassa fever, to do contact tracing, to find other victims who may not know they have Lassa fever. So we observe them and bring them here when they ill, and then we'll do awareness campaign, try to reach the community, to sensitize them, health workers, and other members of the public. But the issue we have now is that we need to build capacity for Lassa fever. This isolation ward, we need to extend it. We need to establish more infection control practice so that our doctors and nurses don't get infected. So we need more consumables. Of course, we need more vehicles for outreach program, because the disease is still, the awareness is still very low. And of course, we need to do research.
So the symptoms.
Okay, Lassa fever, the first thing to know about Lassa fever is that although it occurs with fever, it's usually very difficult to distinguish it from other causes of common fevers like typhoid and malaria initially. So you can have somebody presenting with headache, conjunctivitis, sore throat, then central chest pain, body pain generally, maybe vomiting. See, all these ones are not different from malaria. But as it progresses, or if it's a Lassa fever, you can then have bleeding, swelling of the face and neck, and bleed from the eyes, from the vagina, from all parts of the body, from the anus. When you put a needle into the body, you start to bleed. And before you know it, begin to get confused, become delirious, the person doesn't know where he is again. If there's no intervention, if there's no treatment, after 6 days, usually, it becomes very difficult for the patient to live. Yes. Yeah. Because Lassa fever is very contagious, we don't encourage doctors to treat them in a facility that is not dedicated for that. So we encourage them as much as possible. We either bring them, but if they are too far away, we just advise them what to do. Isolate the patient and then use ribavirin, which is available in the Federal Ministry of Health.
In some instances, we had to send teams of doctors from here to Delta State to be able to, that's during the critical period, to manage very critically ill patients who cannot be moved before we transport them down.
Medical workers, we have what we call the personal protective equipment, the clothes. You have to wear goggles, cap, gowns, gloves, and boots before you approach the patient. If you are able to enter this ward now, you see there's a changing room where you have to change your clothes and put on the proper attire. Yeah, there's a drug, the ribavirin injection. They recover.
Is is that for the past 5 years, no staff has actually died from Lassa. This was unlike before, when staff, when they come down, that's before we were able to develop our facility for diagnosis and treatment. So what we encourage staffs to do, and even members of the public, that if you have a fever, come and just do a Lassa test. It's better for it to be negative, and we reassure you and say, look, just go and continue to treat yourself, rather than assuming that that it's not Lassa. So for our immediate community, as much as possible, and usually during the dry season, what usually happens, because of this unfortunate practice of bush burning, the rats are driven from their natural habitats to the homes. So they are dropping their urine that causes it. So part of our advocacy is that, look, we try to change our practices and encourage people that, look, don't leave food utensils exposed.
We have observed in the last 3 years that the trend is changing. It's not just only dry season. We're now beginning, if you enter the world, and begin to find cases even during the wet season. Yeah, these are research issues. We want to find out the dynamics of this Lassa fever transmission is more than what we know now. The rat does not die. That's the funny thing. It stays. The rat does not die. But if it gets to human being, they could die. Yes.
The Honorable Minister, sir, I just wanted to find out if all the species of rats carry this virus or whatever. No. There's so far we know that there's a particular one we call the Mastomys natalensis. What it does is that if you turn it upside down, and it has this row of breasts that are many, I would call it the multimammet. They have a lot of breasts. So this particular one that causes Lassa. We have tested some other rats in this environment. They don't carry the virus. Yes, then they get infected and they are persistently infected until death. When they're infected, they live with it. They don't die, but they're able to infect man.
And they kill man.
We have vaccinations for smallpox and all the others. Does this fever not have is it not vaccinable? Can't people be vaccinated against it?
For now, we don't have any vaccination that can be used for human beings. Such work is going on to develop a vaccine. That's exactly, and then maybe.
I think part of the things we discovered is that there's some degree of natural immunity built up against but that's part of ongoing research that we are trying to do. So that I think that will form the basis for vaccination, such that at least it protects everybody, because that's the ultimate goal, really, of our center, trying to develop a vaccine that's actually be protective, and even if just but by the time our research is advanced, we should be able to get there.
Yeah, but it can be exported to other parts of the world. Yeah.
Bad product.
And do you think that migration may have also increased the spread of Lassa fever?
Of course, definitely. Inter-country travel, population movement, definitely has facilitated this.
Okay, so I think, sir, I want to know whether you have had any reported cases as a result of the preponderance of this, what do you call it, bushmeat, because they are almost on the same frequency.
Well, not exactly. We have not had that. We have not observed that yet.
Urine, is it?
Urine and the droppings, those little the feces. Yes, we don't see them. The feces you can see, but the urine, you pass urine on Gary, you won't see it. If on bread, you won't see it. On plate, you won't see it. In the morning, so when women want to serve food without rinsing the plate again, might be a problem. The women, we'll tell them to keep their food in rodent-proof containers. You store your food, your Gary in a bucket, plain bucket, and then cover it.
Thank you, sir.
Run an annual can facilitate your access. So I'm saying that since Lassa fever is seasonal, now you say it's almost all season, because the rats seem to be prevalent all year round. I believe it's something that we can collaborate to start a publicity campaign with this center, since you are the one equipped to detect and treat. If you can develop models that we can see together, and develop, a campaign that goes on regularly, particularly radio programs, television programs, and even create a program during that season for you to be speaking, present a program on television during the season, so that citizens get aware.
That would be great, sir. Okay, there's a Lassa fever map there, this building. Just give us
a bit. My question was just about awareness, and I believe the minister has, said it. I just wanted to know what you were doing about awareness beyond Benin and, throughout the country.
Ogun, Danny, yes. Danny.
The community health physician is also an associate prof with the Department of Community Medicine at Bozali University. I want to look around the facility, the things that we do in this place.
Only those ones.